This all-party parliamentary group was set up last summer in order to look at and address some of the gaps in the government response to the pandemic. It set up an inquiry and has had many sessions looking at the different aspects of the coronavirus pandemic. Our very second session was actually on bereaved families and long COVID, which was very new at the time, and it had a big impact in the media. Clearly, this is a gathering issue, and so this week we have had Long COVID Week, where on Tuesday, the APPG hosted another session on long COVID, hearing from the two experts here, as well as other people living with long COVID. And then today, we had a backbench debate in Parliament initiated by ourselves at the All-Party Parliamentary Group on Coronavirus, discussing long COVID. So we have here a panel that is designed basically to address your questions, because opening it up to the public and those that are curious in it is absolutely vital to this discussion. So we have with us again Dr. Nisreen Alwan, MBE, who is an associate professor at the University of Southampton, who is also living with long COVID herself, and immunology professor Danny Altman, who is at Imperial College London. And we have also here Layla Moran, MP, who is the chair of the All-Party Parliamentary Group on Coronavirus. So let's talk about today, firstly, because today was the first ever parliamentary debate on long COVID in the House of Commons. The debate was opened in the chamber by Layla Moran herself. And so if I could ask you, Layla, to give us a summary of what was said and by whom today, what were the main messages coming forward in that debate?
Well, thank you, Mike, and thank you to Nisreen and Danny, who have done an incredible job of influencing MPs up until this point. And I should say, I mean, it really is a moving picture, and one that I'm really proud to say that the All-Party Group on Coronavirus has been trying to push for quite a long time now. And I think we're getting somewhere, although what's really clear to me is that this is really just the beginning and we still have a very long way to go. And you saw that from the response from the minister today. So in my opener, I very much tried to firstly explain to the best of our knowledge what sort of long COVID is. And the main thing I was trying to get across was that for many people who are living with long COVID, they describe it as bad, if not worse, than the original bout of COVID that they might have had in the first place. But also that it can affect anybody, and regardless of age, in a way that actually, if the government took more notice on, would help to drive up compliance. And so our three main asks, which was a national register and recording of who has long COVID, which really very much needs to be symptoms-based, not tests-based. There's issues with tests, not least that in the first wave, they weren't even available to most people. So a lot of them don't know. And if that's a criteria, then you're going to miss huge numbers of people out. And that would help, because if you started to report how many people we think might have it, then actually that would be its own incentive to encourage those who may think that, you know, I'll bend the rules because I myself am not going to be affected. I think it was Danny's comment that really captured the media earlier this week in saying that people are playing Russian roulette with their own health. And actually the government, I don't think, has appreciated how incredible a tool this will be, especially after the first wave of vaccinations, where I think we're going to see a huge drop in compliance after that point. And I'm really worried for that. The second thing was the lack of research and also the moving picture when it comes to the NHS response. And so we spoke about the NICE guidelines, and we welcome them, but they are rudimentary at this point, which is understandable given how much further we need to go. And I'll leave discussion around this point to Danny and Nisreen, but what we can do in Parliament is press on the government to give money to this. And areas that I was pushing on to encourage the government to look at is also the effect on children. And I think that has been something very new for people to understand, that this can affect children. It therefore has an implication in when we think about school safety. We actually don't tend to consider the safety to children because they tend not to get as bad a case of coronavirus in the first place. But if you then start to think of it in the context of, well, actually down the line, it could cause issues with their schooling. How do you phase them back? We heard from some of the MPs today, one set of parents who were threatened to be fined by the school because they couldn't get their child back. Actually, there are important policy considerations here from raising that. And the third area, which is kind of linked, is actually more to do with the adults and the effect that it has on their work and daily lives. And almost every MP that spoke, and I should say there wasn't enough time to get all the MPs who wanted to speak. We literally heard from every single party represented in the House, which is incredible. I think other than the DUP, but I'm sure they wanted to. And the point being that actually MPs are really interested in this now, but almost all of them raised the fact that as people were unable to return to work, those safeguards in the welfare system aren't there. And so it's again raising the fact that the welfare system isn't working. But also we were calling for long COVID to be recognised as an occupational disease in the case of those on the front line. So nurses, I gave an example of a head teacher who caught COVID in the first wave. And of course, as we all know, schools never shut completely. They were there to look after the key worker children, quite right too, but that head caught long COVID and he is now being threatened with the sack because he can't go back full time. And I think that's just utterly unacceptable. So for those frontline workers, we need to now work on a scheme. We've already got a compensation scheme that I led cross-party to get compensation for those who die tragically because of coronavirus on the front line. It's for health and care staff, but we need that now to be increased to include all people who were on the front line for coronavirus who get long COVID. And if we find ourselves in a situation where they cannot work, there needs to be, like there is in the armed forces, and they are our soldiers in this fight, there needs to be compensation for them too.
Right, well, thank you for that comprehensive summary. And I think it goes to show just what a complex problem we have on our hands that has so many multifaceted parts. To just pick up on the first one, with regard to the situation we are at the moment, whereby we are in lockdown and we are rolling out a vaccination program, just before we started this, I noticed some news reported by The Sun that Boris Johnson is being threatened to end lockdown sooner, or there are plenty of Tory rebels that will oust him. Now, there was a claim pushed by the Great Barrington Declaration Group and others that what we should be doing is protecting the elderly and vulnerable, and then after that we can and should largely be going about our business. However, I'm worried now that they are going to say, well, now that we have vaccinated the elderly and vulnerable, let's just get out there. But I think once you factor in long COVID, and as Professor Altman said in that previous session, the roulette of how that might impact each and every one of us, and we don't know how long for, that is a major counterbalancing factor to take on board, and to take on board quickly before we do anything foolish. So, Dr. Alwan, I think for those watching who want to know, well, what is this long COVID? What's it all about? We know that watching this live session, we have lots of people from the growing long COVID community that have gathered together on Facebook and through many other channels. But there'll be others watching this now or watching this later for whom it is a new term and they don't quite know what it is. How does it compare to normal viral fatigue syndrome? Are there any unique features? How serious or severe can it be? So as someone who's someone living with long COVID, but also studying it, what does it look like? What does it feel like?
Thank you so much, Mike. Yes, so long COVID really, to put it simply, is, not recovering from after having the COVID-19 infection for many weeks or months. The picture of what I mean by not recovering is very broad, really. So there are three, let's talk about first is the symptoms. So you can start, you can have COVID-19, you can be asymptomatic, or you can have very mild symptoms. And these symptoms might stay the same if you don't recover and you develop long COVID. They might get better, with time, they might get worse, or they may change. So what we're really seeing now increasingly is there are some new symptoms that develop later that weren't there at the acute phase of the infection, and there are symptoms that disappear and get replaced by something else. So a very big feature of it is the nature of the illness is not steady in most people who are experiencing. It's fluctuating, or it's relapsing and remitting, or it comes and goes basically, but rarely goes completely. But you would have better days than other days, and that makes it very difficult for people in their lives, because you could think you're on the road to recovery, and the symptoms come back. The other feature is the functional ability. So these symptoms are attached to disability, because you experience certain symptoms. For fatigue is very common, for example, but all the other symptoms, whether they're cognitive dysfunction, or whether they're aches and pains somewhere in your body, or whether they're heart problems or palpitations, they are linked to disability. And we're seeing, and worryingly, a significant proportion of those with long COVID experience significant disability, including even caring for yourself, having gone from a completely healthy state, or caring for others, let alone going to work. And basically, it's a very, very broad picture. So some people can manage their life, can manage their symptoms, and can maybe continue to work, or adapt, or have flexible working, as it was actually pointed out very well in the parliamentary debate. It really depends on what sort of jobs and what sort of responsibilities you have, and some can't, and their whole life completely changes as a result.
I remember from the first session that the all-party parliamentary group on coronavirus did with long COVID, where we had someone there who was in a wheelchair. She was young and fit and healthy, a young mother, and then now on a wheelchair. And then from the session that we had on Tuesday, there was that witness who gave testimony that had picked it up in June, I believe, and was still living with it in January, with diarrhea and painful heart palpitations, and was saying that he was seeing new people, because of this second wave, coming into the group and starting to report the symptoms that he first had back in June, which were different from what he was having now. So there is quite a wide variety of severe symptoms here. Professor Altman, what is the physiology of this? How does this virus lock into the body longer term, and what are the different organs it affects, and how?
Well, for the moment, in a way, all I can offer you is my sort of speculation and hypotheses, because we just haven't got the research yet. Yeah, because the research is a work in progress and goes in different phases, doesn't it? All the first phase was counting cases, seeing that this thing existed, acknowledging that it existed, and to be honest, most of what I learned at the beginning came from the support groups and from the people with long COVID. So I'm sitting here like kind of Johnny Big Potato as the expert, but all my expertise came from them, which is very unusual in medicine. So it's a new way of doing it. So so lots of counting and observing, which is a first step, but isn't much use to anybody in the end, because you don't want observation, you want intervention. So how do you get from observation to intervention? By having a kind of testable hypothesis and getting those people in and working out what's going on. And I think there are some good ideas out there from related stuff that we know. So if I had to kind of take a punt on 4 things that we certainly want to look at in our lab, and lots of other people as well, and these aren't mutually exclusive. Idea number 1 would be this is a virus that gets into lots of parts of the body, lots of organs that have ACE2 receptor. And when you do MRI scans, we know they don't recover completely. So you've still got some fibrosis and damage in lots of parts of your body. Idea 2 is that it's like many viruses, it kind of throws a hand grenade into your immune system and kind of subverts lots of the immune subsets, so they don't look the same again for a long time. Idea number 3 is related to that lots of infections, viruses in particular, can trigger full-blown bona fide autoimmunity, so attack against self-tissues. So we're interested in that idea. And then the last idea is that, which has had some support as well and some data, is that there are reservoirs of virus that never quite went away, for example, in the gut, and some people still have it on board, which is why it's kind of coming and going in these kind of long-term persistent waves. So, all of the above, and we need to enter the phase, I said, beyond observing and counting to a bit of doing. Otherwise, it's all very well, and it's very great to acknowledge it and have a clinic with a sort of badge that says long COVID on it. That's not much good unless you know who's going to work in that clinic, what skill set they'll have, what therapeutics they'll be giving out. Otherwise, you haven't got very far.
Yeah, and it's the variety which is a bit unnerving. So as I understand it, the coronavirus itself gets into cells through the ACE receptor, which is right throughout the body. I mean, it's in your vascular system, it's in your gut, to your nervous system and brain as well, to your lungs. And so because it in the initial phase can attack so many organs, which is why you see quite a variety of symptoms. In the first stage of the COVID, you also see that sort of paralleled in the long COVID, where, like you were saying, it can throw a hand grenade into lots of different types of organs and systems. So I was talking to someone from the Physiological Society about, what is the clinical look and feel of this, and they said, well, there's so much variety to it because of that. So given that this is the case, and we have had some initial studies of people who've suffered from coronavirus, then be followed up at 1 week or 2 weeks and found, weakened hearts and so forth and so on. But there clearly needs to be a lot more research, long-term research, on what the impact is months later, because some people are carrying this for months. And so a second question to you then, Professor Ullman, what is the proportion of people who've had coronavirus, COVID-19, that have this severe symptomatology months later, or what's the ratio, shall we say, of people who die from coronavirus to people who continue life with morbidity from coronavirus? What's the estimate of the number of people that we have in our population at the moment that could be living with these problems?
Yeah, no, really important question. And again, it comes out of, it came initially out of the apps and the support groups and things, didn't it? Where my kind of quite conservative estimate, which I think was many people's estimate, was 10% of everybody who'd had the acute infection at whatever level, mild, severe, even asymptomatic. So if you were working on that basis, you'd say that the UK, for example, probably at the moment has 300,000 plus people with long COVID, which puts it about, roughly on par with rheumatoid arthritis, which is, one of the biggest chronic diseases we have in the NHS, one of the biggest, sources of morbidity in the NHS and of cost in the NHS. So, currently 10 or 11 billion pounds per year, but projected to rise in coming years to hundreds of billions. So, I know this isn't a discussion about money, but it just means in terms of, NHS provision and, getting the stuff on board, these are big discussions. And they're big discussions, not least because from what I know about other similar effects and virus infections, I don't know what to tell people. I don't know whether this is a 6-month discussion, a 6-year discussion, or a lifetime discussion. I don't know how long we face this for. But, I said that 10% was my kind of low sort of bottom estimate, because people will have seen there's a paper I'll wave at you that you won't be able to see from the Lancet last week, the Chinese study out of Wuhan, which tells you a few things. First of all, it tells you this is as you'd expect, a completely global cross-national phenomenon. You can't say, oh well, perhaps it only happens in places like England where people are a bit soft and fancy a duvet day sometimes. It's not that at all. It's everybody in the world who's had COVID, and it's serious and it's clinical, and it's absolutely everywhere. And here, in a very large sample out of Wuhan, depending on which of their parameters you look at, it's kind of 25% plus of everybody who had the acute infection. So that would mean, that on the planet we're probably facing 10 million plus cases at the moment of long COVID. That's a big question to grapple with. It really, really is. Big money, big healthcare provision, big clinics, lots of doctors, and as we alluded to a moment ago, which doctors are they? Which specialty do they come from? Are they, rheumatologists or infectious diseases or endocrinologists or neurologists or a bit of all of them? And how do you get them all together in the same place at the same time if you've never planned for this?
Yeah, Absolutely. So we know that it's an international phenomenon because as we research it, we see that in a lot of other countries, there's a lot of long COVID groups developing, and they're starting to look at what we're doing here in the UK in terms of how we handle it. We were looking at that today. And as you just pointed out, the potential health and economic hangover from a large long COVID burden is huge. We don't know how long it lasts for some people, whether it even will be lifetimes, and we've seen certainly in some cases extremely severe. So we do need to be planning for that now, especially given that we have had the exposure levels that we've had, particularly in the UK. So that then brings me back to Layla before we open it up to questions from the audience here. And that is, what happens next, Layla? We had a debate in Parliament today. Is this just politician chatty chat, or is there a structured plan going forward as to how we must tackle this, get ahead of this before it starts really having much more of a burden on people's lives, on the workforce, on the economy? How do we handle this?
Thanks, Mike. I think this is well, actually, I think Danny's just put a number on it, 10 to 11 billion pound a year question, because actually what we need to do as politicians, and you say politician chat, but actually to get them to chat in the first place and take it seriously enough to spend time chatting about it, actually, I do not think should be underestimated. And actually that's credit to everyone who might be watching, who wrote into their MPs, who have told others to do the same. And I'll repeat it again, please contact your MP if you are someone who hasn't yet done that. And even if you think they'll never reply, it doesn't matter. They will see it ping into their inbox. Their staff will tell them about it and they will start to take it more seriously. And I think we need to get them to understand that actually a stitch in time saves 9 or indeed 10 or 11 billion, which is that if we take this seriously now, we could end up saving a huge amount of money down the line. And there are some MPs who just simply think in those terms. I don't. I actually think about quality of life. And I think there are many other reasons why we need to think about that in the immediate term. But the campaign needs to be big and it needs to be now, because as you've alluded to, there are those who are pushing Boris Johnson in his own party to release, as soon as we've had that first 4 categories, the most extremely vulnerable, the over 70s or whatever, then to basically release much quicker and probably go back to the very flawed tiered system. And the all-party group on coronavirus very early on was advocating for a zero COVID strategy. We morphed that into, once we realized we sort of passed the point of no return because the government never got to the point where we could get to zero COVID, we rebranded it, if you like, as a COVID secure UK. And the feature of that they really need to take on board is to ensure that cases don't go up again. And that once we get the virus under control, we then work through test, trace, isolate, through paying people to isolate and cut those chains of transmission to keep those numbers going down, not allowing them to go up just slightly slowly until you hit exponential growth again and then it takes off. And that is my concern. So if we can get the long COVID message across and make them understand that by doing that, they are helping people not get long COVID and saving themselves money in the long run, that I think is the key to how we're going to get through the next few months, increase compliance. But to do that, we have to convince government first. And that's where everyone watching comes in. We cannot do this alone. You have to help us. We have to do this together.
Absolutely. This is now a big community effort from groups like Long COVID SOS, from ourselves, from all of the MPs that have been incredibly supportive, and to all the wider community that are interested in pushing and developing this. In fact, we have a petition going at the moment, and we'll share that link from the March for Change social media channel about recognizing long COVID as an occupational risk that needs to be duly compensated. And for those frontline workers in the NHS that are being directly exposed to all of this, at least first them need to be taken care of properly. So there's lots of different pieces to this puzzle policy-wise. And we, as a big community, need to be all driving at this fast so that we're ahead of the curve in this instead of caught out. So let's go to questions now, because as we've been talking, there have been questions absolutely streaming in, and I'm having them sort of pinged through to me on my phone by our March for Change team. And so the first one, I think, to address is actually back to properly understanding what long COVID means for people who get it and then have to live with it. And so I'd like to address this to Dr. Alwan, please. And that is from Rachel saying, how common are all the different symptoms which can be experienced? So I guess if you do get long COVID, how likely is it that you're going to be suffering from brain fog? How likely is it that you're going to have painful heart palpitations? How likely is the diarrhea? How likely that you'll be on crutches or in a wheelchair? I mean, I guess to broaden it out more widely, to put it more scientifically as it were, if you contract coronavirus, what's your proportion of it being asymptomatic? What's your proportion of dying? What's your proportion of going to hospital? What's your proportion of having this long-term symptom and this long-term symptom and this long-term one, so that people understand the risk in that fuller context?
Yes, really good question. A lot of it is unknown, just to tell you the truth, and that's what we need the research. But we've got a better idea now than a few months ago, thanks to research who actually contribution from all the long COVID patients, but also led by long COVID. So we've had a great study recently come out from the Body Politics Support Group, who actually, so it's a patient-led research where they looked at the symptoms in long COVID, and also we're analysing, me and our team are analysing some results from another survey at the moment. The results really tell us that there are some patterns emerging, and there are some symptoms that become much more common later in the illness, predominantly the cognitive dysfunction. So the brain fog and the poor memory and concentration seems to not be that common at the start, but become much more common later. There are some symptoms that become less common. So, classical fever and cough that, some people continue with them for months and months, but on the whole, on a group level, on average, they become less. And there are some which, stay or, also develop. So, for example, that feeling of, chest tightness or chest pressure, chest heaviness seems to be an ongoing feature for many people. So the issue about what's the percentage is that this research is based on surveys of people who are experiencing long COVID. There isn't really research, comprehensive research of everybody who gets COVID, and then looking at the symptoms later. So the ONS, so the figure of 1 in 10 comes most recently from the Office of National Statistics study. So this is a prevalence survey. So they sample a random sample of the population and test them for coronavirus. So they would pick up even the asymptomatics. It's a great study, but actually, when they've produced these statistics, they've asked about a certain set of symptoms which were set from the start, before we knew the wide variety of long COVID symptoms. So it doesn't completely pick up all of the long COVID symptoms. It picks up, only several of them. So, and that's why actually even the 1 in 10 could be an underestimate of the true prevalence. So what we need is big studies that would follow everybody who has long COVID, who has COVID, and then ask them. And we've got the setup because we've got the test and trace system, no matter how good or not very good this is, and we would hope after this lockdown this becomes a major part of controlling the infection. You can actually get back to people once they've tested a few weeks later and ask them about their symptoms. So it's a kind of a big national study that could help us reach these answers.
Yeah, so you would need probably a big classic national follow-up study, or maybe international follow-up study where you're pooling data on people who've had it. And then you probably want 2 parts, I'm guessing, the survey part, which is their self-report, but then also get them in to see doctors for all those physiological indicators to see if they have any weakening of their systems, which means that they're more liable to health problems going forward. I think that could be a hidden risk that we haven't properly addressed yet. So let's move on to other questions. And there is a question from John Keel Bennett saying, have you discovered any similarities between long COVID and ME? Professor Altman or Dr. Alwan, any answers to that?
Yeah, well, I probably haven't got anything big to contribute to that, simply because what I said before, that we're at the start of the story and it's uncharted territory, and I'm hoping that as it evolves, we'll have a lot of cross-fertilization and hopefully have some good answers for both. But I don't know what Nisreen thinks, but for my taste, it's sort of early days.
Yes, I mean, I completely agree. I do think if we really invest in researching long COVID, that is also a big benefit for the ME and chronic fatigue syndrome community, because it's been largely neglected. You know, and there will, you know, I suspect there will be, you know, common things. You know, the long COVID is like an umbrella term at the moment, and that's why we want to continue to use it, because it doesn't have any judgment about what it is. It's just saying, you know, there's this disease and it's going on and it's long, and the research would tell us maybe that, you know, how it shapes. So maybe a subset would be very similar to ME.
And that's a perfect segue into the next question, which is from Claire Hasty in this webinar, and I'll throw this to Layla. What can we do to influence the fact that the NHS website still only lists 3 symptoms? So talking about the whole variety of what we've got and using it as an umbrella term, like the communication to the public doesn't seem to have caught up with the understanding yet. So how do we get the policy engine running so that this is all working on faster speed and keeping people duly well informed? What do we need to do?
Well, that's really interesting, because the NICE guidelines that were released a few weeks ago have certainly more than 3 symptoms. And so if that is the set of criteria that they're asking clinicians, then they really ought to update their website. And in fact, I would ask, my email's layla.moran.mp@parliament.uk. If you want to send me a link to the page, I will aim to get that changed, because that's silly. But actually, I think the way that we are going to ensure that we've got the most up-to-date information is to ask for transparency from the government and from the NHS about what they're doing. Today was the first time that I heard the minister stand up on the floor of the House and actually update the House on what the NHS was doing. I see some people in the chat, and forgive me if I'm preempting a question here, Mike, have been talking about the long COVID clinics. Well, I mentioned in my opening remarks that it's great that there are 69 of them, but actually it's also quite patchy. And there are lots of people who can't access them at all. And we keep hearing, for example, in Wales, there are none. So we need to know that if there is someone who has long COVID, that first of all, if they go to their GP, that is something that the GP will go, oh, okay, I know about that. I think one of the things that is a bit of a feature of long COVID, and I was talking to a colleague of mine who runs the all-party group on ME, we were chatting last night. She sees this by and large, and the community, the ME community, sees all of this as a positive thing for the reason that Dr. Alwan was saying. I mean, this is now going to be a moment where we can shine a light on other conditions that maybe haven't had the same exposure. But it also is helpful that quite a few medics and people with a medical background are getting this. And I say that helpful is maybe the wrong word, but I think there was a feeling in the ME community that a lot of GPs and frontline workers don't really understand what ME is, that it's kind of all in the mind, and it's sort of not something you feel physically, and a level of feeling that GPs don't really quite get it. But actually, I think long COVID is a moment where they may not get it, then they may not have long COVID, but it's highly likely they know someone now who probably does, and they will not just take the NICE guidelines as gospel, but actually will also have those personal relationships with people who do have long COVID, and that could be transformative in the way that not just long COVID is treated in the long term. We still don't know. Is it a subset? Is it the same thing? Is one causing the other? We just don't know, and that's why the research is so important. But it's long past due that ME and CF and others have been taken much more seriously than they have done, and that's really, really, I think, a positive thing. If there is any silver lining to be taken from this, it's that.
Right, so this could really open the door on a whole range of issues which need to be better addressed. I mean, I found it remarkable on Tuesday the fact that there were several hundred doctors and frontline staff in the long COVID SOS group or community, I believe, which I think is really informative because, of course, the frontline staff are in a COVID heavy environment, but also they are not usually old and vulnerable themselves. Many are not. And so when you actually build up that density of professionals in this area, recognizing that this properly is a very strong condition in themselves that they have to live with, then that makes for very powerful advocates. And to follow on from that question, again with you, Layla, Ondine Sherwood has asked, how can we make sure that the government takes account of long COVID in policy decision making? So moving on from just the structures in the community to go and treat people themselves, clearly we're going to need broader policy changes in order to handle this, whether it relates to the frontline staff and compensation for when they can't work, or whether it moves to how the government recognize this clinically, what's going on at the policy level in order to be able to handle this new phenomenon.
Yeah, so since August, and I found the evidence that we took in August really powerful. And one of the things that we were quite disappointed by is we then wrote a letter to Boris Johnson, and in there in particular was firstly a recognition of long COVID. So to be fair, at least the government then started calling it for what it was and developed the NICE guidelines and everything else. So something has moved already. But the thing on the employer guidelines in particular, we asked them 4 months ago to look at this and they haven't yet. So some of this will be pressure. I'm pleased to see, I've just seen it ping through, that we've, as a result of today's debate, secured a story in the Telegraph. And you've got to put these stories in newspapers that government ministers and other Tory MPs are going to see, because bluntly, that's how we're going to affect government policy now, is by convincing members in the Conservative Party that this is something that we need to take really seriously. So especially those who are in Conservative areas, write to your MP. I'm going to say it over and over again because it does make a difference, and it will make a difference. And if they start to see that there are constituents of theirs who care about this, I was really struck. There was a Conservative MP who stood up, and one of his constituents is the woman who set up the long COVID kids group, and really movingly told her story and her family's story. And I thought to myself, right, there's an ally, and there they are on the other side of the house to me. And that's great, because no one cares for party politics right now. They want us all to work together, and quite rightly too. But the government has never quite understood that it needs to be humble in the face of science. It needs to understand that this is going to change and move, and that's not their fault. That's no one's fault. The only fault you have is if you don't change your mind when the evidence changes, when you see new things that crop up, that you don't say to yourself, oh, well, I said something else last week, it's going to be seen as a U-turn. Politically, I can't do this. Actually, real leadership is to look at new information and then change what you're doing. So that's very much what we're trying to work on in Parliament. But I will say this over and over again, the big push has always come from the community. I think it's wonderful that there's almost this co-creation of medical research that's happening right now. It's wonderful. And we need to do the same in terms of policy development in this area as well.
Yeah, I am delighted to see it being so cross-party in nature. That's the purpose of the all-party parliamentary group on coronavirus, but also it being picked up by media all over the place. So just from the Tuesday session, we had BBC TV, BBC radio, and BBC online coverage. And we also had it in The Sun with, I think, a headline or top lines along the lines of, to the youth, don't believe that you're invincible. And I think that itself was a very, very important message. So to come back then to some other questions, because we've got about 5 minutes left to get through the others. So if we could just do some rapid fire on some of the others that I want to get through. And to everyone who can't get their questions in, I'm ever so sorry. Please keep sending us questions at the All-Party Parliamentary Group on coronavirus on Twitter or at the March for Change campaign, because with the official secretariat, we will try to address all of these, or to our experts if they're willing to take them. But other questions to fire through from Sonia Moss. Is there currently research on those with long COVID and inflammation markers? Professor Altman or Dr. Alwan?
Well, I can say for my part, yes, it's all kicking into action now. So, it takes a while to assemble all the groups and the ethics and the clinics things. Yes, that's all kind of kicking into gear now, and answers will be very rapid.
But as to inflammation markers associated with long COVID?
Yeah, but that means, I take it, serum biomarkers and things.
I presume so, yeah.
Yeah, so all very much a work in progress, and like everything else that's happened in COVID, it's going to come at us thick and fast. So so watch this space in the next few months.
Right. Okay. Another question from Rachel Homer. No, we did that one. Peter Bishop, will the vaccine help people with long COVID?
Danny, do you want to take that?
Yeah, no, I'll do half a minute first. So I know this is a kind of a worry and a concern to people, because when I speak to people with long COVID, there are a lot of unknowns out there, and some people think they might have it because they have too little immunity to the virus. Some people think they have it because they have too much immunity to the virus, and this confusion isn't because they're stupid, it's because there just isn't enough data and enough tests, so nobody knows and we're all guessing. So my simple answer would be, long COVID is caused by COVID. The way not to have COVID, and certainly not to be reinfected by COVID, is to have the vaccine. So I would really recommend anybody who can grab the vaccine to grab it and be that much safer with some good neutralizing antibodies on board.
Right.
Mike, can I just come in for 20 seconds about your earlier question, because that's an important message about the initial symptoms. Most other countries recognize many more symptoms than the 4 symptoms that the official symptoms, to get the test here in the UK. And I would really, I think this is really important, and I would urge the government to widen the symptoms that indicate testing. And it's surprising that they're talking about mass testing in schools, etc. Well, actually, if you go and book a test online, you have to tick one of these symptoms, and there's just a wider range of symptoms. So it's really important for people to get the test if they're unfortunate enough to develop long COVID, to being one of those 10%. Even now, it would be really helpful for them to have that evidence of having been tested in the early, if nothing else, in the early stages. So yeah, recognize the wider symptoms.
Right. And another question in this last minute, just before I wrap up, and this is from Joe House. Why are long COVID clinics for assessment and not for treatment? Why are they for adults and do not include children? Who wants to take that one on? I see Layla nodding. So would you?
Well, I want to know the answer too.
Yeah, I think we're all thinking, well, that's a valid question,
really
and
question.
It's not yet been well developed enough in order to handle that.
Exactly. My understanding is, though, that some people are, I don't know how each and every clinic works. And actually, one of the things that we've been raising is that probably there is best practice that is happening among the clinics to suggest that they're going to be standardized completely across all 69 is highly unlikely. And so we need to be looking at their effectiveness. And there is a big range in reports from people who have gone to clinics, and some have had a great experience and been treated from there. And I think one of the reasons, though, that we're struggling with this is the same reason we often struggle with these multidisciplinary diseases. The way that medicine it carves up the body and you become a specialist in one little bit of it, but long COVID affects all parts of the body. So we need to develop an approach that's truly holistic. And that was what we were calling for in the House today, was for the Minister to ensure that the NHS is looking at this in a way that is joining up all the different bits of the system, which also incidentally includes financial support as well. And that's what and mental health. I see people in the chat have been mentioning mental health. We mentioned that as well. We need a lot more research in all sorts of different parts of this, but I suspect that that's what's going on. Yeah. I don't know.
And that's a good point to wrap it up, actually, on the actions that we need going forward. I would like to say for anyone watching, who is living with long COVID and wants to join a support group, that we highly recommend the Long COVID support group on Facebook, which has over 33,000 members and is a support and is a source of support for those who want it and need it. If you know anyone that is living with long COVID or suspects that they are, then also recommend that to them. We would also encourage you to follow us on Facebook and on Twitter, follow either the March for Change campaign itself or the All-Party Parliamentary Group on coronavirus on Twitter, and also do help us with our petitions and with our campaigning on this. So you will see we have at the moment, like I mentioned before, a petition up looking firstly at the NHS frontline staff who have come down with long COVID. They have been working in that high-risk environment and they need all the due support and they need that properly. And once we open the door for them and get that from government and get that from the system, then we've set the model whereby we can be looking at all the other aspects of long COVID that also need proper support around it. So yeah, we are here to help this issue thoroughly, so please help us to do that. Thanks very much, and thanks again to Dr. Nasreen Alwan, Professor Danny Altman, and Laila Moran, MP, who is the chair of the All-Party Parliamentary Group on Coronavirus. Thanks ever so much, and feel free to keep in sending questions and comments after this live session ends. Thank you.
Thanks.